Hi, everybody. The recording system starts at 2 o'clock, so let's begin. All right. So, RCTs. Here. Disclosures. So, why do we need to have RCTs? Well, it's impossible to completely exclude the possibility of biases and more than anything else confounding when you're looking at observational studies. So if you have a very careful design, you can be pretty certain that you don't have any major biases, but what we call residual confounding, the confounding that remains after you do all your possible adjustments, is always a possibility in observational studies. And therefore, whenever it's feasible and ethically appropriate, we like to have an RCT to answer our questions. It doesn't matter how obvious or logical your observational data may be. The rationale for approaches that are not tested may prove to be wrong. And that has happened time and time again in recent medical history, and that's why it's so important to emphasize that. A very, very striking example, because it involved mortality, was the CAST study. So in the good old days, when people had an MI, we thought that most of the sudden death right after the episode was related to arrhythmia. And we thought it was essentially VTAC degenerating to ventricular fibrillation and people dying. Later on, we learned that most of the mortality actually comes from reocclusion of the culprit artery. But in those days, our emphasis was on trying to prevent arrhythmic death. So in those days, we loved to use encanide and flecainide because they actually were proven to be very efficacious antiarrhythmic drugs in the laboratory. The FDA approved them, we were all prescribing them, and the most used approach was to take people to the EP lab after the MI, induce arrhythmia, and then suppress it with different infusions. And whatever drug suppressed the arrhythmia was the drug they were put on later on. It made a whole lot of sense at that point in time, but nobody ever had tested that in an RCT. So the CAST study randomized more than 2,000 people post-MI to either receive an antiarrhythmic drug or placebo. So what did it show? Actually, the study had to be stopped earlier than expected because death rates in the antiarrhythmic arm were actually almost 3 times greater than in the placebo arm. Why was that? Well, because we didn't know, we didn't keep in mind the possibility that antiarrhythmic drugs may actually give you a pro-arrhythmic effect, generate a different type of arrhythmia, more specifically a certain type of torsade de pointe arrhythmia with QT prolongation that will become quite frequent in those patients. So we were actually completely wrong until we performed the CAST study. And I cannot tell you how many post-MI patients who were determined to be high risk because they had very low ejection fraction post-MI and had many PVCs when they had Holter right after their MI were put on these drugs. So that's just a very striking example. A much more recent example is the ACCORD trial. It had different arms, but the one that had the scariest finding was the one where they tested very tight glycemic control in diabetics. So they took high-risk diabetics and they randomized them within that arm of study to either getting the usual conventional treatment of their diabetes versus getting very tight glycemic control, trying to lower the glucose as much as possible. And actually, that had been the recommended approach by the American Diabetes Association for decades. And what happened is that the study had to be stopped early because people in the tight glycemic arm were dying more frequently. And they never quite figured out what killed those people, but we did learn that it's probably not a good idea to go for very tight glycemic control in somebody who is high risk. That's just another striking example of something that seemed to make sense to the medical community, something that many people were doing, and then were proven completely wrong. So the most important consideration, of course, is always first do no harm. So in terms of conducting RCTs, first of all, we need to keep in mind the protection of study participants. And this seems to be a strange conversation to be having in the 21st century, but to this day, many RCT participants are not being given full information about what they are enrolling into. And this is actually completely unethical and extremely important to keep in mind. You guys are going to be the institutional review board members of the future. You're going to be in the IRBs. You're going to be advocating for the safety of RCT participants, so it's extremely important for you guys to keep in mind. You really need to respect the autonomy of the potential participant by providing full information in a way that's actually accessible to that person. Like when you pick up a consent form and it's full of lingo that a lay person with college level education couldn't understand, and you give that consent form to somebody who's functionally illiterate in Spanish. You can't imagine how frequently that kind of situation actually does arise. So what is equipoise? Well, equipoise is just the fact that even though we have this idea, we have a priori data suggesting that my treatment works, we're not entirely sure that it does. And that is the reason why we need to have an RCT. And it's a balancing act, because if you're so sure that it works, why can't you just use it? Why do you need to try it in an RCT? Well, because of the examples I just gave you. So equipoise implies that we still have a modicum of uncertainty about whether the treatment is better than placebo if there is no prior treatment, or better than the standard of care if there is already a treatment. So you guys may be in the IRB at different universities, institutions in the future, but there's another potential role for people who would like to protect the rights of trial participants, and that is to be part of the Data and Safety Monitoring Board. Nowadays, thank God, every RCT is required to have a DSMB. And the DSMB is usually composed of people who have no financial interest, who have no strong bound to the investigators, and it should include at least one good statistician who understands data and how to analyze it. And it's a responsibility of the DSMB to monitor study results as it goes on to make sure that participants are protected. And a fantastic thing that happened a few years ago was the creation of a registration system known as clinicaltrials.gov. It was a very small step, but it had a huge impact. Why am I saying that? Well, because nowadays in the United States you cannot perform an RCT unless your study is fully registered within clinicaltrials.gov beforehand. And in that registration you need to explain to the world what type of study you're going to conduct, inclusion, exclusion criteria, the type of intervention, the type of analysis you're going to implement, and so forth and so on. So there is complete openness nowadays. It's not like the good old days when people just did whatever RCT they wanted to do locally, and then if they like the results, they will submit them for publication. If they didn't like them, they will just put them in a drawer and forget about it. By having prior registration, you actually agree that you notify the world when your RCT is completed and you have your data. So if you complete your RCT and you don't publish, your study gets red flagged. And it actually becomes obvious that there is publication bias. So this is actually a huge step. And in Europe, most people send their studies for pre-registration to the Cochrane Registry of Clinical Trials. So those are the two registration sites. There are still places in the world that are not protected by this system, but we're hoping that it's going to be a global reassurance system, that there's going to be openness throughout the entire world. So when you are designing and conducting an RCT, the first thing you need to keep in mind is that you want to minimize the probability of mistakes, of errors. So what type of errors can you have? And the way I usually put it to medicine residents is the way you'll never forget which one is which is to remember that human nature makes investigators want to make their point. It's your drug, you want it to be good. It's your surgical procedure, you want it to work. So you're much more likely, even if it's unconscious, to err on the side of saying that it works when it doesn't. And that's the type 1 statistical error. Okay? Type 1 is rejecting the null when the null hypothesis is actually true, is saying that your treatment works when it doesn't. It's a probability of a false positive result. And we have this magical number that a guy called Alvin Feinstein came up with in the late 1960s. He wrote an editorial, and then he wrote another one in 1973. And he said he liked the idea of a p-value being less than 0.05 as a safeguard against type 1 statistical error. And we are stuck at that level ever since. What you need to remember is that it was completely arbitrary, and the fact that it's stuck for decades doesn't make it any less arbitrary. And that if you're looking at something like the the possibility of harm. If you're looking at a serious adverse event and you have a p-value of 0.06, you may want to give a whole lot of thought to that and not just dismiss the evidence because it didn't reach the magical threshold of p less than 0.05. So you need to apply your common sense always. Type 2 is the probability of not detecting a treatment effect when it's there. It's the probability of a false negative finding. And we are usually, logically, much more lenient in terms of the amount of type 2 error we accept. And therefore, we are usually okay with keeping this probability at 20% or lower. That means that the power, the statistical power, which is 1 minus beta, should be 80% or greater. Okay? Again, these are arbitrary numbers, but the bottom line is most people will use those when they are trying to determine whether the sample size for their study is big enough to give them power. And all the estimates that go, all the assumptions that you need to make in order to come up with the sample size required to make your point will be targeted towards achieving a power of 80% or greater. Sometimes you're going to have privately funded studies when they think they have a very good investment, like all the erectile dysfunction drugs. Most of them had RCTs with power of 90% or greater. So it really depends who's paying for it, but for the most part, the NIH funds RCTs at a level of 80% power. So once again, we would like to have at least 80% power and keep the probability of error at less than 5%. So we need to make sure that we have enough power. The most important determinant of power is your sample size. So how do you determine how big your sample size has to be to give you enough power? First of all, you need to know your disease process. You need to know how frequently the outcome will take place with the standard of care, be it placebo or available treatment, and that is the event rate in your control group. By understanding what's going to happen to your participants in the control arm, who are going to be receiving the standard of care, you will be able to predict how frequently they will have the event over the follow-up time. The more frequent the event, the easier it is to detect an effect. So if you have something that gives you a mortality of 90%, of course it's going to be much easier to detect the reduction from that 90% to 80% mortality than it is to detect a 10 percentage point reduction from 20 to 10. The more frequent the event, the easier it is to show that you can reduce it. Okay, so that's your benchmark. That's where you begin. That's the first question any statistician is going to be asking you when you're designing your study. How likely it is that participants in the control arm will have the event during your follow-up period. The next one, of course, is how well your treatment will work, and we call that the effect size estimate. In other words, how much you're going to reduce the event rate that you expect to see in the standard of care arm by introducing the new treatment. But then you need to keep in mind that actually bad things happen to good people, and you make a very good effort at recruiting participants who are willing to come back for follow-up visits, people who commit to taking the allocated treatment and to stay in touch with you. But, you know, sometimes it just doesn't happen. So you need to plan for any losses to follow up, and that's particularly important when you work in an environment like ours, where our potential participants face many socioeconomic circumstances that can be very challenging. Then crossing over is also very important. Crossing over means that you've assigned somebody to the placebo arm, but that person, impressed by the consent form, decides not to take the study pill. They don't know what they're taking because it's blinded, and they just decide to go buy the drug because it's available in the Dominican Republic, and they just like the idea of taking the drug, so they go straight to taking what we call an open label medication, something they know what it contains. So if that person was assigned to the placebo arm, that person effectively crossed over to the treatment arm by taking the pill. Sometimes it's actually impossible to blind the study, like in the defibrillator trials, when we put in defibrillators to people post-MI with low ejection fraction, and we saw what happened. And some people assigned to the control arms decided, hey, they're already FDA approved, I've got $20,000 in the bank, I'm just going to get one, even though I got assigned in an unblinded manner to the control arm. So crossovers happen that way. They also happen when you're assigned to the intervention arm and you decide not to take the study pill because you don't like the taste, you don't like something about it, it gives you alopecia, acne, whatever, and you stop it, and therefore you're effectively crossing over to the control arm. Either type of crossover will dilute differences in treatment effects, because people who are supposed to get the treatment are not getting it, and people who are not supposed to get the treatment are getting it. And at the end of the day, the event rates are going to be more similar because of the crossovers, and that will give you a loss in statistical power. By making the two arms more similar in terms of outcomes, you are going to lose statistical power. And finally, anything that makes it harder for the intervention to be implemented may actually cause a loss in fidelity, meaning it's just not carried out in the way you expected it to be, and that happens quite frequently actually when you do behavioral modifications. You know, I did a small study a couple of years ago. We looked at the efficacy of community health workers to do a behavioral intervention to change the care in people with diabetes in our community. And we wanted to have a whole lot of in-person meetings with the participants to have these community health workers help them eat better, take their medications better, and whatnot. Our participants had a very hard time attending the in-person sessions. They had to babysit for grandchildren. They sometimes were working without letting us know because, you know, they were getting paid on the table. And you name it, you had 1,000 different difficulties attending the in-person sessions, and we had to create a phone-based intervention. So it actually gave us quite a bit of trouble with intervention fidelity in the study we performed. So this is just an example of how to design and conduct an RCT. It's the MADE-IT CRT study. So all the MADE-IT studies looked at defibrillators. The CRT actually added cardiac resynchronization therapy to the defibrillator function. And we already knew before the study was conducted that patients with heart failure and reduced left ventricular ejection fraction were at high risk for death related to arrhythmia and heart failure. And we knew that ICDs improved their survival and reduced the risk of sudden death. But we also knew that people could keep on having heart failure events. And that's where cardiac resynchronization therapy came in, and we started thinking about using that in people who are still symptomatic, and for some reason we hadn't implanted a defibrillator yet, and they had a prolonged QRS interval of 120 milliseconds or more. So what did the investigators hypothesize? They thought that this resynchronization added to the defibrillator capabilities will reduce the risk of death and heart failure in people with milder CHF. So we were already doing this for people with more severe CHF, and now the idea was to see whether it could be, the application could be expanded to New York Heart Association classes 1 and 2. So who got included? The usual 21 or older, people with ischemic or non-ischemic cardiomyopathy. They had to be in sinus rhythm because if you're in AFib, you actually lose synchrony of the ventricles anyway, and it's impossible to resynchronize. And they had to have pretty low ejection fraction, 30% or less, and have a QRS duration that actually is associated with much greater risk of dying and much greater benefit from defibrillation. And everybody had to meet the guidelines for the implantation of AICD at that point in time. So people who already had an indication for resynchronization therapy obviously were excluded. People who were having a pacemaker implanted, because at that point in time we didn't have the capability of doing all three things, so they didn't qualify. When they had more advanced symptoms, because they already qualified for that. And people with recent revascularizations or recent myocardial infarction. So inclusion criteria. The inclusion criteria essentially aim to define who will benefit from this. And that is people, again, with very low ejection fraction, very wide QRS, and symptoms that are still mild. But in terms of the exclusion criteria, it's always important to think about what are the underlying themes, what's the rationale for excluding people. Well, first of all, it's not ethical to randomize somebody to get or not get CRT if you know that they need it. So that's a pretty obvious reason to exclude those patients. obviously, if they already had a device implanted, it's very hard to remove an old device and implant another one. So we don't do that unless we're going for open heart surgery for another reason, and at that point in time, we change the device. And item C is very important. People who were likely to have a different natural history of pathophysiology. If you think about people who just recently got revascularized or people who just recently had an MI, the most important factor to drive their short-term prognosis is actually how much residual ischemia they have and what is the probability of having a major coronary artery reoccluded. If you are dealing with that at the same time that you're trying to prove your point that you can prevent arrhythmic death by resynchronizing the ventricles, you're going to be in trouble, because you don't know how many patients may go into each arm of your randomization design, and they may actually act as outliers. They may actually create a whole lot of confounding, because imagine you just get a few people in one arm with a lot of ischemia and they die, but they're dying from reocclusion of the coronary artery, and that has nothing to do with resynchronization therapy. So this is a general theme in RCTs. You need to remember when you're designing your study that the exclusion criteria will frequently clean up your experiment by eliminating people who may not benefit to the same degree or may have a different disease process with different pathophysiologies that would not benefit from your specific intervention. So it's not unusual to see people with recent MI, for example, being excluded from these studies. And obviously, as I said before, people who recently had an episode of atrial fibrillation are at high risk of going into AFib again, and AFib doesn't really allow you to have CRT. CRT doesn't work when the patient is not in sinus rhythm. So this brings up to the issue of internal and external validity, because whenever you are cleaning up your experiment, whenever you're excluding participants based on their characteristics, you are trying to make it a very clear intervention on a very homogeneous group of people. And that increases your internal validity. However, when you do that, you're going to lose applicability. You won't be able to generalize your findings to a wider population. Why? Because you excluded them from your study. And it's a natural price to pay for this. And sometimes people talk about weaknesses of RCTs. I prefer to speak of limitations, because sometimes this is actually a very logical thing to do, and there's nothing wrong with doing it. Okay? Just remember that the more you clean up, the more restrictive your exclusion criteria are, you're going to have better internal validity, but you're going to lose some external validity. For some reason, people who write up the questions for step 2 and 3 just love this, so it shows up in every iteration. So just remember, there will be something about internal and external validity. Just remember, external is applicability, internal is how clean your experiment is based on how homogeneous your population happens to be in terms of pathophysiology. So randomization. This is where it all begins, and we actually give a whole lot of value to this. Why do we randomly assign people to one treatment arm or another? Well, pretty obvious. We want to avoid selection bias. We want to avoid investigators assigning healthier people to the intervention arm so they'll do better with the intervention. We actually did have in the past the opposite situation. People who are desperate to get a treatment and they were sicker actually got the intervention more often, and then when you analyze your data, it looks as though the intervention doesn't work that well, because people who are sicker got selected more often to get in it. So we want to stay away from the 4-letter word, from bias. And just a reminder, there are 3 things we do when we are conducting a clinical trial to stay away from bias. The first one is we randomize. The second one is, does anybody know? What do you do to stay away from bias? Blinding, perfect, and you double blind whenever possible, but sometimes you can't because the intervention is not available to blinding, like when you put in a defibrillator or when you perform a surgical procedure. There have been sham surgical procedures for minor surgeries, but you're not going to do a sham surgery for a major surgical procedure. So sometimes you can't double blind, so you blind the person doing the ascertainment, the person determining whether the outcome is present or not, and the people doing the analysis. And finally, at the time of the analysis, what do you do to stay away from bias? You apply what principle? Intention to treat? and we're going to go back to that. Intention to treat just simply means that you keep participants in their groups of randomization, regardless of whether they cross over or not at the time of analysis. So you assign somebody to treatment A, and regardless of whether the person took or did not take the pill, if that person has an event, you count that event within the analysis for treatment A. Okay? So why do we do that? Well, because again, in the past we had situations in which somebody in an open label study will come in, or maybe was blinded, but it was easy to figure out who was on what, and they will come in and they wouldn't look very well, and they will say to the investigator, you know, I'm not feeling very well, and the investigator will say, yeah, your prognosis doesn't look too good, so why don't you just stop taking it? And then when that person had an event, that event got analyzed in the placebo arm. You can see how bias can be generated that way. So we apply the intention to treat principle at the time of analysis, and actually you can think of it as analyze as randomized. It's actually an easier name to remember instead of intention to treat. Okay, so allocation concealment just means that we do randomization in a manner that cannot be modified or messed around with. So you have this automated system. You call in, and it's a computer that answers, and you give the computer the participant ID number, or you log in through a VPN, and you enter the participant ID number, and the computer remotely will give you a randomization assignment and put that in a database, and that cannot be modified by anybody. Again, this was created because in the past we had instances in which somebody will make a phone call to a randomization center, and the randomization center will say, your next participant is an intervention participant. And the person on this side of the call said, well, she looks pretty sick. Are you sure that she's intervention? And the other person will say, oh, wait a minute, let me try again. No, I made a mistake. As a matter of fact, she's going to your placebo. So to avoid that type of bias, we have this approach that has to be completely automated, and it cannot be modified by any human being. And we call that allocation concealment. Again, very frequently, this item shows up in step 3. I'm not sure about step 2, but we see it all the time when the interns take step 3. So what is the other thing we're trying to stay away? We're trying to stay away from confounding. How is confounding generated? Well, confounding is generated when you have a smaller RCT, and within that smaller RCT, when you randomly assign people to the 2 or more treatment arms, you just, because of poor luck, get people with much higher risk of the outcome in one of the arms. And that can confound your assessment of the association between the treatment and the outcome. In a very large RCT, in a mega RCT, that's not a possibility. Why? Well, there's this thing called the central limits theorem, which just simply means that if you toss a coin 1,000 times, you're extremely likely to get very close to 500 and 500, or 499 and 501, or something like that. Now, if you toss the coin only 10 times, it is actually more likely that you'll get something different from 5 to 5 than it is that you'll get the exact 50% distribution. So it's important to remember that in smaller RCTs, you may have some confounding, because the lack of huge numbers keeps you away from the central limits theorem. So what do you do? Well, you need to remember that the factors you worry about are the ones that can be associated with the outcome of interest. And that's when you need to think in terms of the biology of what you're dealing with. And you want to try to make sure that that specific covariate is not imbalanced in its distribution between the 2 arms. So this is the way confounding takes place in a smaller RCT. In the CRT arm, the investigators worried that people with ischemia, myocardial ischemia, could be unevenly distributed depending on on what treatment they got. And ischemia by itself is associated with mortality. So this is the typical graphic for a confounder. It's a third characteristic that's associated with the exposure and is independently associated with the outcome, meaning it's not a mediator between the exposure and the outcome. Okay? And when does this happen? When you have a smaller clinical trial. So in the case of the MADIT CRT, they thought that people with ischemia will die more often, and therefore they didn't want to have any confounding by ischemia. So how do you deal with that? Well, you stratify randomization. In other words, you divide your sample, in this case, by ischemia versus absence of ischemia, and for each group, you draw the numbers from a different box. At the end of the day, you ensure that the randomization will have an even distribution of that confounder, of that characteristic, between the two arms of the study. The stratification at the randomization stage keeps you away from any confounding by important characteristics. Of course, there is a limit to the degree to which you can stratify by different covariates. I've seen stratification work for up to 3 important covariates, but beyond that number, it's actually too complicated to implement. But if you're doing a study in the ICU, for example, you may be able to stratify for up to 3 important potential confounders. So essentially, by ensuring that ischemia will not be associated with any type of treatment assignment, you eliminate the possibility of confounding by it. So in large RCTs, there's one thing that you may want to stratify for, and that is center assignment, because you're going to be enrolling people from many different centers all over the world. And even though it's a huge study, some centers may contribute only 20 or 30, sometimes 15 patients, and you want to make sure that they're evenly distributed across the 2 treatment arms. Why? Well, the answer is pretty obvious, because if you have a very high standard of care, your doctors and nurses are all fantastic, and your standard of care is out of this world. If you assign everybody to the intervention arm, there may be confounding by the fact that you're just doing a good job, and if all your participants are in the intervention arm. So you want to have equal assignment to intervention and control per site. So you're going to frequently encounter this little sentence in many RCTs when they say stratification by site was performed. Is it clear? All right. So this is a step forward. It's within the context of the stratified randomization. Block randomization, specifically by site also, just make sure that as you go on, as you advance recruiting and randomizing people, you get similar numbers in both treatment arms. And how do you do that? Well, instead of having one huge pool of numbers to draw the randomization from, you have blocks of randomization assignments, and those blocks tend to be small, 5 or 10. It's usually an even number, so it's usually 6, 8, or 10, or something like that. Why is it an even number? Because at the end of the day, you want the number of intervention and control participants in each little box to be similar. So each time you randomize a block of 10 people at Columbia University, you're going to be sure that within those 10, you have 5 and 5. The order in which they were assigned to intervention and control will vary, so you won't be able to predict it. So that's why we call that permuted block, because the order in which people are assigned to intervention and control within each block is being changed. It's being permuted. Okay? So it sounds a little complicated, but it's actually not that complicated. It's the stratification approach, and just means that stratification is being performed within small boxes with a limited number of slots, and those slots will be assigned in even numbers to each group. And this is the example I was describing. So here you have Columbia, and Columbia will have 2 bins for non-ischemic and ischemic for mated CRT, and you're going to have also blocks within those bins. Do you understand? All right. So what they actually did employ was a 3-to-2 ratio randomization. I don't think I included that in the slide, but why do you think you may want to do a 3-to-2 randomization ratio instead of 1-to-1? Right. So even though you still have equipoise and you need to prove your point to the world, you have pretty strong data and you feel that it may not be ethical to have the same number of people assigned to the old treatment as to the new treatment, and you may decide to give more people the new treatment. And the other reason actually is related to that, and it has to do with enrollment, with recruitment, because patients who may have death as an outcome may be coming to you as volunteers because they want to get the new unapproved treatment. And this happens a lot in chemotherapy, when you're dealing with palliative chemotherapy, when people have tried all different drugs and nothing has worked, and there's one potentially new drug that may work. People don't sign up because they want to be in the placebo arm. They sign up because of the possibility that they may get the treatment. And yes, you require overall a larger sample size when you have 3 to 2. However, the number of people exposed to the new treatment is going to be larger during the trial, making it easier for you to recruit participants, and also from an ethical perspective, you feel better about it. Of course, what you're going to do is you're going to monitor what happens throughout the study, and if you prove benefit, you're going to stop early and offer the treatment to the control participants. Once again, blinding is extremely important. Whenever we can, we're going to do double blinding. Sometimes double blinding is not feasible. You can't blind the intervention, but at least you need to make sure in that instance that the ascertainment, the people doing the evaluation of the outcome, those people are blinded. And the other things you need to keep in mind is that if you cannot blind participants, you cannot use softer outcomes. You cannot ask people questions about quality of life as your primary outcome, because obviously that could be biased. If people know what they are on, they can give you a biased report of what's going on in terms of quality of life. So we try to use harder outcomes, things that are very objective, such as stroke, myocardial infarction, and of course death, when we are assessing things that cannot be blinded. So follow-up. In this case, in the case of the MADID CRT, they had a total of 173 crossovers. And also devices were removed in the trial for a variety of reasons. So when people have their devices removed, or when they actually got a different device from what you plan to implant based on randomization, you have a problem in terms of crossing over. And then when people don't come back, they decide not to continue participating in your study, you lose information. So when you have those two problems, you can have issues with power. So finally, we're getting to the point when you're ready to analyze your data, and as I said before, analyze as randomized, okay? You analyze people in the group they were randomized to, regardless of what treatment they actually got. Intention to treat simply means analyze as randomized. Obviously, when you do that, crossovers will give you a loss of power, but you're willing to pay that price to stay away from type 1 error, stay away from the possibility that people are manipulating the data, the behavior of participants, just to show that the treatment works. So we know that intention to treat may be associated with loss of power when you have crossovers, but it's still the gold standard approach because it keeps you away from bias. So study monitoring. As I said before, you guys are going to be part of the DSMBs. So what does a DSMB do? Well, first of all, you look at the data every once in a while, and you tell the investigators, I think you're doing a good job. You may keep going, or you may say, no, your protocol is not being adhered to. There is something wrong here. You need to review what you're doing because this is not what you proposed to do. And also the other possibility is that the outcomes are clearly telling you something. They're telling you that the treatment really works, and there's no doubt about it, and therefore the control participants should be allowed to get the beneficial treatment. It could be that unexpectedly you have caused harm, and that's obviously the most important reason to stop right away. Or it could be that there is no difference and that you are just beating up a dead horse and there's nothing to it. And you keep recruiting patients and randomizing them as you collect data about the outcome. The outcome actually looks identical in both arms. So futility is the other reason to stop. This is actually a pretty good graphic from the MADID CRT investigators. The MADID investigators did an outstanding job protecting the welfare of their participants throughout the several studies they performed. And this is something that DSMB applied, the method the DSMB applied to monitoring outcomes and deciding to stop the study. So this is simply a plot over time of something we discussed the other day, which is a median comparison, the comparison of the median survival between the two groups, which is the log rank statistic. And if it's 0, it means there is no difference. A positive log rank means better survival in the intervention arm. Negative means that there is harm, that you're actually having less survival in the intervention arm. And you have a predefined boundary for efficacy, a predefined boundary for harm. In this case, it's symmetrical. We actually nowadays prefer an asymmetrical boundary in which your tolerance for harm is less. So you will have the inferiority boundary over here, higher up, because there is no ethical reason to tolerate the same amount of harm as the amount of benefit you need to prove that your treatment works. So we prefer asymmetric boundaries. But nevertheless, this is what happened. Every time they took a look at the log rank statistic, it kept on going up, suggesting benefit, and when they crossed the predefined boundary for significance, they said, we've proven benefit, we can stop. So it really doesn't matter how they came up with the actual boundary. What matters to us as clinicians is that they had a very well-defined plan through which they made sure that every once in a while they took looks at their data, and once they were sure that people benefited from the intervention, they stopped and offered that intervention to participants in the other arm. So composite primary outcome, this is something you're going to see all the time. Most of the RCTs you're going to encounter don't have a single type of outcome as their primary endpoint. Rather, they put together several things. Very commonly in cardiology, we put together death, myocardial infarction, and stroke, and whatever happens first in each participant will be the event for that person. So if that person has a stroke and later on dies, you only count one event, which is the first one to take place, which is the stroke. And in MADIT CRT, they had a composite of death and also heart failure events because they thought that resynchronization will actually improve heart failure in these patients, and it made sense to them to combine them. So obviously, death and heart failure exacerbations don't have the same value. And we want to know if there is any impact on the primary outcome, whether it actually worked for the two components or not. So that's always important. So what happened when you look at the primary outcome in MADIT CRT? When you look at the composite of death or heart failure, huge effect. A hazard ratio of 0.66. If you remember from my talk the other day, you interpret this just like the relative risk. So if you do 1 minus that, you get the relative risk reduction. That will be 34, right? 34% reduction in your risk of dying or having an exacerbation in your heart failure. Very significant p-value with that hazard ratio. When you look at the individual components, which one did it work for? Look at the hazard ratios for heart failure only and for death at any time. Right. All this is just coming from heart failure improvement. There is no effect. The hazard ratio is 1. That's identical to a relative risk of 1. The event rates are almost identical in both arms, meaning no effect can be appreciated on death. So is that bad? Well, not necessarily, because it's not causing any harm. And if you're keeping people feeling better and keeping them away from the hospital, if you're preventing CHF exacerbations, that can actually be a remarkable outcome to be had. Now, when it comes to societal conversation, though, things change. If you are in an environment where these devices are extremely expensive and you have a national health system that's going to absorb the entire cost, you may want to have a conversation as to whether something that doesn't change mortality is your top priority in terms of getting that bought and implanted. When it comes to a chaotic system like the one we have, well, here it just depends on how well you cope with the system. It's pretty clear that no managed care company really wants you to have a CRT device on top of your ICD because they have to pay more for it. So there will be bureaucratic barriers for you to go through. But if you're well motivated, you will probably get approval and you'll get it implanted. So again, there was an improvement in the risk of heart failure events, but there was no reduction in mortality. But we're reassured that it did not increase the risk of death. So the question now is there a risk of bias for the ascertainment of heart failure events? So this is important. Members of the Heart Failure Adjudication Committee were unaware of study group assignments, but the investigators who decided on therapy or hospital admission for patients with heart failure were aware of such assignments. So it is possible that the investigators' knowledge of the study group assignment contributed in some way to the lower frequency of heart failure in the CRT ICD group. And sometimes that's not really malicious. It's not a conscious effort to produce bias. It's just the fact that if you really believe that resynchronization works, when you see somebody who has that resynchronization in place, and you see the same degree of lower stem edema and the same amount of crackles in the lungs, you may be less impressed by that as compared to somebody who doesn't have the resynchronization. Because in the back of your mind, that really works, and the person without it is expected to do worse. So if you want to protect that person, you may have a lower threshold to admit that person to the hospital and get that person through the IV diuresis process. You understand? It doesn't have to be malicious. It doesn't have to be a really bad intention on the part of the investigators, but if they're really convinced that it does work, they may be biased in terms of the treatment they provide to participants. So moving on, subgroup analysis. So we want to know whether the treatment effects are the same regardless of who you are. So what do we call a situation in which who you are changes the way you react to an exposure or to a medication or to a device in this case? We call that effect modification or interaction. And this is different from confounding. Confounding, as I said before, is associated with the exposure and is independently associated with the outcome. A factor that gives you an interaction or an effect modifier does not need to be associated with the outcome. In other words, oftentimes we see interactions by gender, and we see that the intervention works differently, has different efficacy depending on whether you're a man or a woman. That doesn't mean that your gender actually increases the risk for that outcome in any other situation. The baseline risk may be the same, but what changes is the way your treatment works depending on who you are, and we call that interaction. So that's an important distinction between confounding and interaction or effect modification. So when people give you that final table in the RCT, when you open up a New England and you go to an original article that happens to be in RCT, the final table is always subgroup analysis. Sometimes it's a figure. And, well, quite often it's a figure. And what you're going to have there is a visual display that will allow you to decide whether you think there's an interaction or not. So you're going to go up and down that figure, and you're going to take a look, and you're going to see what's going on. So essentially, it's going to look like this. Okay? You're going to have point estimates and confidence intervals, usually 95% confidence intervals around those point estimates. So the point estimate is the most likely value given your data. Okay, the most likely value for the test statistic is your assessment of the relative risk or the hazard ratio within that subgroup of people. And then, of course, you're going to have 95% confidence intervals around that. So how do we look at a plot like this one? Well, you begin by looking at the main comparison, the one for the entire group of patients. One arm versus the other in everybody, the main result. Okay? So we then take the point estimate for that result, and there's usually a vertical line going across that point estimate, and you see how the other point estimates for each one of the subgroups compares to that. And what you're looking for is a point estimate that deviates from the overall effect, from the effect in the entire study population. Why are you doing that? Well, because again, you want to see whether one characteristic or another is associated with a different point estimate, with a different treatment effect. So when you see that deviation, then you're going to have to assess whether there is an effect modification or interaction. So what are the rules to interpret the subgroup analysis? Rule number one is you start with the primary comparison and you look for consistency with it. So this is important because we have a concern about multiple comparisons when people go fishing for results, and in absence of a positive finding in the main study, then they go looking for effects in subgroups, and they say, oh, yeah, it didn't work for the entire group, but for people who are taller than 6 feet, it worked beautifully. Look at this. You should give it to everybody who is very tall. So sometimes it's not as silly as that. They will give you something that has the semblance of biological plausibility, but you can trust me, they went fishing for many hours until they found that p-value they needed. So you start by looking at consistency. Why? Because if you have a positive finding for the main comparison, obviously it's much more likely you're going to have a positive finding for every subgroup. If it works for everybody, it is likely that it works for all the different subgroups. So you need to beware of subgroup comparisons that appear to give you benefit when the overall finding for the study was negative, because that will be highly suspicious for a fishing expedition. So number 2, remember, at the end of the day, everybody's a Bayesian. We always take into consideration a priori information when you assess any result. So the question you have to ask yourself, does this finding make any sense? Or is this possibly just a false finding? So people who do pure statistics will tell you that the probability is the same, but at the end of the day, we don't work like that. We work in terms of trying to understand the disease process, and yes, sometimes we make mistakes, but at the end of the day, when you have a result, you look at the result and you try to put it together with your biological understanding of the disease process. So you're not going to be surprised if you see an interaction when you expected that group to have more or less benefit because of the fact that they have a different pathophysiology. But if you didn't expect that, then you're going to be suspicious. So, for example, when they did the subgroup analysis, they already expected that people with wider QRS will have more benefit. And that's why they included people who had a QRS wider than 120 milliseconds. They didn't want to include people with normal with QRSs. So when you do this and you see that there is a pretty good distance between the point estimates for people with less than 150 milliseconds and more than 150 milliseconds in QRS width, you know that this is statistically likely to be real and biologically plausible. And that's essentially what closes the deal. It's biologically plausible. Here you have some different effect in terms of gender, and there's a tiny overlap between confidence intervals. So the p-value, even though it's less than 0.05, is less impressive than in this situation. And the other thing is, you really need to think hard. Why could this be? And yes, there may well be an effect modification by gender or an interaction with gender, and we just don't know the mechanism, but it's certainly much less obvious in terms of biological plausibility and statistical significance as compared to QRS duration. So when you look at the effect depending on ejection fraction, you have complete overlap. When the point estimates are included in the confidence interval of the other statistic, you're absolutely sure there is no interaction. I'll repeat that. When the confidence interval for one of the results includes the point estimate of the other one, in this case happens in both cases, you're absolutely sure there is no interaction. The p-value for this effect modification must be greater than 0.05. Okay? That compared to an instance like this one, in which there is complete separation, the p-value for this interaction will be less than 0.05. So I think that's it for RCTs in general. Do you guys have questions? I know it's a lot to absorb, and you have a neuro exam coming up. Yeah.
How is the power determined?
In this study, like in any study, I'll go back to this slide, but as I said, what you need to take into consideration is event rate in the control arm. The more frequent event rate, the smaller sample size will be, because it's going to be easier to detect an effect. But if it's a rare event, you're going to need a huge sample size. So event rate with the standard of care in the control arm. That's number one. Number two is how efficacious an intervention is.
So it's not a simple equation.
It is, you know, it gets complicated when you are powering for a specific type of analysis, because essentially you're fitting all the data into a specific type of analysis, like a hazard ratio, for example. Then you need to know how the Cox proportional hazards model works. But if you're doing it simply, if you just want to do a yes or no, a 2-by-2 table type of comparison with the crude relative risk, then the equation is very straightforward. But what matters is this. As I said before, event rate in the control arm is the first thing you want to know. Then how much you're going to decrease that. We call that effect size estimate. Then bad things that could happen to you, whether losses to follow-up are likely to take place. In some environments, they don't have any losses to follow-up. We do have quite a few. How many people you expect to cross over from one arm to the other, and how likely it is, this is related to compliance and crossing over, how likely it is that the intervention will be implemented as planned. So you have all those things into consideration, and you say, I want to have at least 80% power. If you want to have 90% power, are you going to need a larger or smaller sample size compared to 80% power? Very good. If you want to prove your point at a p-value less than 0.01 instead of the usual point less than 0.05, are you going to need a larger or smaller sample size? Larger. Okay. So the most important assumption is usually the event rate in the control arm. Quite frequently, people really overestimate the event rate in the control arm because things were much worse in the past, and there are secular improvements, meaning we all get better at treating the disease. And then when they actually carry out the study, the event rate in the control arm is lower than expected, which is a great thing for study participants, but it's really bad news for your power. That's unfortunately the case. Whatever is bad for participants is actually good for the statistician, because when you have something bad that happens very frequently, it's easier to prove efficacy in your trial. So we're going to talk about these items when we do the review session, because there are certain things that are extremely important for you guys to remember for the future, and therefore will be in the exam for sure. By the way, there will be no questions about genetic epi in the exam. The idea was just to expose you guys to certain principles in that, and nothing that we don't discuss here and is not addressed in the small group sessions will show up at the exam. You know, it's not a matter of torturing anybody. You get enough torture from neuro. We're not going to give you that. We just want to give you the ability to pick up a journal and read different types of articles, okay? So at the review session, we're going to go over all the important topics for one more time. All right, so they want to take a quick break, and then we're going to do non-inferiority. guys, we're going to get a start again. Non-inferiority. So why do we care? Well, we care because this type of design actually has been used and abused, and you may guess who has been abusing this type of design. Going over the safety of trial participants and sometimes getting approval of treatments and drugs that are actually not quite efficacious. Non-inferiority designs are sometimes difficult to interpret, and that's why many people in the medical community have been excluded from the conversation. And it's up to you guys to change things in the future. That's why, in my view, it's so important that you should understand what the issues are and be conversant in terms of how to deal with those issues so you can be active participants in the dialogue. Because whenever we leave a void, somebody will take over that space, and sometimes their agenda is not the one you wish it to be. So it's just extremely important for everybody to understand how non-inferiority trials are designed, conducted, and interpreted, okay? I cannot tell you how many of my colleagues, how many people who are actually in clinical practice don't understand how they're designed and analyzed. So I hope that won't be the case for you guys, and you're going to be able to be comfortable with this conversation and change the tone of the dialogue. So when do you consider some treatment to be non-inferior? Well, you consider it to be non-inferior compared to the available older treatment if its efficacy is better, equal, or not significantly worse than that of the old treatment. So this is the essential difference with superiority trials. Now you're accepting some harm. You're accepting some loss of efficacy as part of non-inferiority. So how much harm we accept as part of non-inferiority is, from an ethical perspective, a very important issue. So why do we need to have non-inferiority trials? Well, first of all, placebo-controlled trials will be not acceptable if you already have a treatment that works, right? You cannot deprive somebody from a treatment and keep them in a control arm that's placebo when you already have an active treatment. But we may have a new treatment that's similarly efficacious as the old treatment, but adds something in terms of being more tolerable, being safer, being more acceptable because it's given once a week instead of once a day, or is much cheaper. So from a societal perspective, you may want to switch from the standard towards a newer, cheaper treatment that won't imply any loss in efficacy. So this is important when I go back to this checklist. Actually, this is in your EBM glossary, the one that's included in the main document for this seminar. There are 8 questions that you need to ask yourself, and we're going to go through each one of these. There are 8 questions you need to ask yourself when you're looking at a non-inferiority trial. First of all, and this is actually extremely important because this hasn't been discussed at length in the past, was the non-inferiority threshold ethically and clinically sensible. What this means in plain English is that whether the amount of harm that investigators decided to accept as part of non-inferiority actually made clinical sense. It made sense for your patients. It made sense for other human beings. So you also want to make sure that the control arm actually is a good reflection of the best standard of care. And let me just give you a very brief example. We've had a newer category of drugs in treatment of cardiovascular conditions known as angiotensin receptor blockers, ARBs, and they were essentially developed after ACE inhibitors were already in the market and were shown to be beneficial for many people, like people post-MI, people diabetics with macroalbuminuria, and the list goes on and on and on. Many people with high risk for cardiovascular events benefit from the use of ACE inhibitors. But ACE inhibitors can give you angioedema, they can give you cough, and therefore we needed an alternative. And that alternative was purported to be ARBs. Now, the trick is, when you look at the non-inferiority trials for ARBs, over and over again, they picked an ACE inhibitor that has to be taken 3 times a day.
to work. That's captopril. We never, ever use captopril in the outpatient setting. We may use it when somebody comes in very hypertensive, so we can titrate up the dosage every 8 hours, but when they go home, we give them a 24-hour ACE inhibitor. No clinician in his or her right mind will ever prescribe captopril TID for the chronic management of these patients. However, that was the standard of care, between quotation marks, used in non-inferiority studies of ARBs over and over again. So next, you need to make sure that they actually had enough power, because they recruited the number of people they expected to recruit, that, like we discussed before, whether the event rate in the control arm was what they expected it to be, whether they had crossovers and losses to follow up, whether the intervention was appropriately implemented. And then finally, we're going to have a different type of analysis on top of the usual intention to treat analysis. We're going to have something known as treated analysis. And we're going to discuss why now we need to move away from that paradigm that we apply for superiority RCTs, in which we always do the intention to treat analysis. So in this case, you also want to see whether they analyze data based on what treatment people actually got, and we call that as treated analysis. So this is a type of analysis that we use only for non-inferiority trials. Okay? You're not going to see this in your usual superiority RCT. And finally, you're going to make an assessment as to whether the study results actually suggest non-inferiority. So when you're having a superiority trial, your hypothesis is that you can reduce mortality, for example, with the new drug compared to the old one. So your null hypothesis in terms of that reduction in mortality is that mortality on the new drug is equal to or greater than the mortality on the older drug. So if the p-value is small enough, you reject the null hypothesis, everybody's happy, and you've shown superiority. So this is usually the way we display the results. This vertical line here is relative risk of 1. Event rate is the same in both treatment arms. That's a null hypothesis for superiority. So this is a good result. Your point estimate suggests reduction, and your upper confidence limit does not include the null hypothesis line. Everybody's happy. You have efficacy. Here you have a situation in which there seems to be a trend, but you cross the null hypothesis line with your upper confidence limit, and therefore you're not sure. And we call this a non-significant trend. And finally, this is the result of the CAST trial I mentioned before, or the Accord tight glycemic control. Your point estimate suggests that you cause harm, and you're sure that you did it because your lower confidence limit does not include 1. So when you are dealing with superiority trials, again, as we said before, what are the things that will give you a loss in power? What are the things that will increase the probability of type 2 statistical error? Well, when you have too many people lost to follow-up, when too many participants cross over, or when you have low intervention fidelity. The behavioral management intervention could not be implemented, or people just didn't take their pill. So all those things will increase the probability of type 2 error in a superiority trial, okay? They will give you a loss in power. However, now we're going to move on to non-inferiority trials. And non-inferiority trials are changing the hypothesis and therefore the null hypothesis. The weird thing about biostatistics is that we're actually testing and rejecting the null hypothesis if it is unlikely. That's as close as we ever get to proving the hypothesis. Okay? So what is the null hypothesis we're trying to reject now? Well, now we're trying to reject the null hypothesis that we are causing harm with the new treatment. In other words, our hypothesis now is that the mortality on the new drug is not greater than the mortality on the old drug. That means it could be less, it could be the same, or not significantly worse. So this is the null hypothesis we're trying to reject now. Given that the null hypothesis has changed, we can't use the same old statistical test we used before. So non-inferiority trials are a relatively new development. They were first implemented in the 1980s. They took hold in the 1990s, and ever since then, we've seen a greater number of non-inferiority trials, sometimes with very good reasons, like in oncology, when they're trying to find things that are equally efficacious but less toxic, and sometimes in other fields like cardiology, when manufacturers essentially wanted to have a Me Too drug or device approved by the FDA. So essentially there was already something working, manufactured by somebody else, and they wanted to show that what they produced was equally efficacious, and they came up with non-inferiority trials to make their point. So how do you assess the study results? As I said before, you can't use the same statistics that you use for superiority studies. So you need to use a different approach. And now we only care about one side of the confidence interval. We only care about the confidence limit going in the direction of possible harm, because that's the only one in our null hypothesis. We don't care about the other side anymore. And our threshold, our null hypothesis line, which used to be a relative risk of 1, will have to move, will have to be placed somewhere else. It's going to be to the right of that, and we'll see a graphic for that. So how much further to the right you're going to be is actually the crucially important decision. So this is now your null hypothesis threshold for non-inferiority. It's to the right because it goes in the direction of harm. You're not interested in this anymore because what you want to exclude is the possibility of doing harm. If you cross this line, you cannot reject the null hypothesis in non-inferiority analysis. So where it is actually extremely important. So going back a couple of slides, what matters the most is understanding that the non-inferiority threshold you choose is extremely important. Why? Because it's the amount of harm you're willing to accept, both for participants in the trial and for patients who may receive the treatment later on. And I cannot emphasize how many recently approved treatments actually got through the FDA approval process thanks to a non-inferiority trial. So in terms of the confidence interval, again, you only care about the upper confidence limit. You don't want that upper confidence limit to cross this line, the null hypothesis threshold. So this is an exaggerated example. This is a very lenient, a very permissive threshold. It allows for a lot of harm to take place. And essentially, now we have 3 possible results. In this case, you have a point estimate that's actually on the good side of things. There may be a tiny reduction in the risk of the event. And the upper confidence limit is actually quite narrow, and it stays away from this. So this is actually pretty good in terms of indication of non-inferiority. This one, you just don't have enough data, because that confidence limit, that one-sided confidence interval is just too wide. So that suggests you didn't have enough power. But in terms of how the investigator will see this, they'll say, oh, my treatment is not non-inferior. I cannot reject the null hypothesis. What's actually ethically questionable is this possibility. And it is a possibility when you have a lenient threshold. This point estimate actually suggests that you may have harm. And your upper going confidence limit doesn't cross the permissive threshold, and therefore the investigator can say it's not inferior. It's equally efficacious based on non-inferiority. Now, from a purely statistical point of view, if this is their predefined threshold and nobody challenged that, they are absolutely right. Is this the right thing to do? Will you take this drug? Will you prescribe this drug to a relative of yours? Never ever. However, we do have that possibility when non-inferiority trials are designed with very lenient thresholds. The good news is that pharmaceutical companies, for the most part, do their homework very carefully because the pipeline narrows down and they really take out of the pipeline drugs that are highly harmful and non-efficacious. So this type of finding is not a frequent one, but it is a possibility. And it has happened, and we need to keep our eyes open to that possibility. So what are the major differences between a non-inferiority and a superiority study? The most important thing is that it's an upside-down world when it comes to issues of statistical error. So things that gave you loss of power, a higher probability of type 2 statistical error, now will give you a higher probability of type 1. Why is that? Because things that will make the two groups look more like each other in terms of the outcome, in terms of the risk, will go for your hypothesis. Because we moved the equal sign from the null hypothesis to the hypothesis. Now we're saying if the two treatment arms look similar in terms of outcomes, we're not inferior. So if you lose too many people to follow-up, if you have too many people crossing over, and or your intervention fidelity, the way people adhere to the treatment, are not good, you actually have a greater possibility of a false positive finding, okay? Greater chances of a type 1 statistical error. So it's extremely important. And that is the reason why you are not going to ask only for intention to treat analysis as we do for superiority RCTs. You're going to ask for what we call the on-treatment analysis. Sometimes they call that per protocol, which is a very confusing name because the protocol should be the protocol for the RCT, but nevertheless, that's sometimes out there in the literature. I prefer to call it on-treatment analysis. So you're going to ask for that on top of the usual intention to treat analysis. So if the study is properly designed with only a small amount of harm accepted as non-inferiority, the bottom line is that the sample size will have to be big. Therefore, whoever is funding this will have to spend more money. And that is the reason we tend to see lenient thresholds, because people don't want to spend a whole lot of money making their points. So whenever you look at a non-inferiority study, you first look at the control arm. And again, as I said before, make sure that it actually reflects the best possible standard of care. Okay? And it's also important to remember that in this case, it's fundamental to look at the event rate in the control arm. In this case, again, if you have a very low event rate, you can have a greater probability of type 1 statistical error. All the things that gave you loss of power in a superiority study will give you a greater risk of a false positive finding. Okay? Things that gave you a risk of false negative now will give you a risk of false positive. And this is extremely important. You may find a drug to be non-inferior when it actually is inferior. So, this is the usual example I bring up. And this applies not only to the Valiant study, which is valsartan versus captopril, also to the Optimal study, which is losartan versus captopril. And I could go on and on and on about all the non-inferiority studies for ARBs. Most of them use captopril in the control arm. So what are the ethical considerations? Well, the most important thing is that when the outcome is really bad, when we're talking about death or major disability, then it may be completely unethical to have a non-inferiority trial, unless you really monitor the study as it goes on and you have very good stopping rules, like the ones I showed you before for the MADIT CRT trial, in which the DSMB takes a look at the data every once in a while and says, I don't think this is ethical anymore because you may be causing harm. Now, the trick here is how you're going to make it work if a little bit of harm is actually part of your hypothesis. So how lenient are you going to be when people are actually enrolled in the study and you monitor them as it goes on? So by definition, having a non-inferiority design will make it harder for you to apply very good monitoring rules. Do you guys understand that? The way we ensure safety of participants is that we have predefined p-values or values of the test statistic at points in time deviating from no difference at all. If you now are accepting some harm as part of what's good, between quotation marks, by definition, your stopping boundaries will also be more permissive, meaning people in the trial will be exposed to greater risk, potentially, than participants in a superiority trial. So many people have argued for quite some time. There was a fantastic editorial in BMJ in 2011 by two Italian guys who actually essentially said it's completely unethical to have non-inferiority trials when your outcome is severe because you're betraying the trust of trial participants. In other words, who ever said in a consent form, by enrolling in this study, you may be exposing yourself to a higher risk of death as compared to the standard of care. However, we consider that increase in risk to be small enough that it's acceptable. If you said that in plain English or in plain language in every consent form, how many people do you think will actually sign up for non-inferiority studies? They usually have a very accurate but completely obscure sentence explaining that it's a non-inferiority study that very few participants actually are able to understand.
It seems like really different processes for, say, chemotherapy and avoiding toxicity.
Absolutely. So there are very ethical reasons to do non-inferiority studies, absolutely. When you have an efficacious treatment, but that's very toxic, and that's the case quite often with the older chemotherapeutic agents in oncology. So in oncology, there are very ethical studies being conducted with very careful monitoring, but the non-inferiority is actually aimed at preserving efficacy in terms of mortality, for example, but improving quality of life. So you do that by actually explaining to participants how you're going to monitor them as you go on. And as I just said, in the field of oncology, for the most part, people have performed very ethical studies. Now, in other fields, that has not been the case. I don't have any. I don't think I have slides about the optimal trial. The optimal trial was losartan versus captopril, and essentially it was for post-MI patients. And we knew that people post-MI with heart failure or documented low ejection fraction had a very high risk of death, and that we could reduce that by giving them an ACE inhibitor. And people who qualified for that were randomized to losartan versus captopril. And at the end of the day, what happened was that the relative risk was 1.13 for mortality in the losartan arm. So on average, the risk was how much higher for death during the study? 13%. How would you like to contribute your participation to a study like that? A study in which your risk of dying could be 13% greater, so you can contribute to the advancement of marketing of losartan. How acceptable is that from a societal perspective? How did that go through institutional review boards? How were people consented? As a matter of fact, I requested that they share the consent forms with me, and they wouldn't do that. I'm actually writing up about this topic because if you go to the website of most institutional review boards and the best funded institutions in the United States, none of the IRBs actually have guidelines for non-inferiority trials. We take that issue very seriously here. We don't have them online, but we do have a review process that we keep working on to look at non-inferiority trials in a different way from the way we look at superiority trials. Again, there are very ethical non-inferiority trials. Please don't walk away with the impression that non-inferiority design is bad. There are very ethical ways of doing this, and the example is in oncology. The other example is when the outcome is not that dramatic. For example, when we look at bone density and the risk of fractures, we used to prescribe Fosamax, which is a bisphosphonate to enhance bone density in women with osteoporosis, and we used to give that daily. And there was a non-inferiority study in which Fosamax once a week was compared to Fosamax once daily, and it was non-inferior. So that's a beautiful non-inferiority study. We all benefited from that. There are many non-inferiority studies in antifungals, for example, because amphotericin B is a beautiful drug in terms of efficacy. It's a horrible drug in terms of side effects. Very few people tolerate it. So we keep looking for antifungals that will give us the same efficacy but much less toxicity. So there are very good reasons to do non-inferiority studies, but when you have an outcome that's death or major disability and you have a standard of care that actually really works, it becomes a very complicated ethical issue that should be discussed by everybody. And the point I'm trying to make is that for the most part, the medical community has been completely outside of this conversation. We haven't collectively engaged in this conversation. And when you look at the FDA guidelines for the conduct and interpretation of non-inferiority trials, they have a few notes, statistical notes here and there for antimicrobials, for oncology trials, but they don't have clear guidelines from the perspective of ethical conduct of trials and what it means for participants. So let's go back to this. Can you do a superiority analysis in a non-inferiority design? Yes, you can. It's possible because actually one null hypothesis is part of the other. So where do you begin? Well, obviously, you need to prove that you're not inferior before you can ever prove you are superior. So it's okay to do a non-inferiority analysis and then move on to do a superiority analysis to see if you're actually more efficacious than the older treatment. But if you cannot rule out the null hypothesis for non-inferiority, it makes no sense to look at superiority. That makes sense, right? Very good. So the methods that people use to determine that non-inferiority significance threshold are pretty obscure. And again, if you Google FDA guidelines for that, you're going to see that some people have written papers about how to preserve 60% of the efficacy of the old treatment, and they give you formulas that very few people understand. And usually in papers, when you look at the method section, what they talk about is the absolute risk difference between treatment A and treatment B. So we're going to talk about that for a couple of minutes. So the threshold, again, represents the amount of harm that we're willing to tolerate as the worst case scenario. Because if you cross that with your upper confidence limit, right, which is your worst case scenario in terms of probability distributions, you're going to say, I am not non-inferior. So if you have a threshold that's close to relative risk of 1, that's very ethical because you don't accept much harm, and you're quite likely to have a point estimate on 1 or to the left of 1. But if you have a very lenient threshold, then that's essentially unethical because you may deem a new treatment as non-inferior when it's actually, from a commonsensical point of view, actually inferior. So how much harm are you willing to accept? So the point I always make to the medicine residents is go back to the tools you're familiar with. And there are two things we always do in superiority studies. We estimate the relative risk. Remember, divide event rate in the treatment arm over event rate in the control arm. That gives you the relative risk. And the other thing we do is we do the number need to treat. We do the absolute risk reduction, event rate in the control arm, and you subtract from that the event rate in the treatment arm, and you do 1 over that, and you get number need to treat. If you don't remember the formulas, you go to MedCalc, you put the numbers in, and MedCalc will give it to you. However you do it, you keep going back to relative risk estimates and number need to treat. Well, let's use those for non-inferiority, and let's look at harm. So again, if you have a situation like this one, in which the threshold is very close to no difference in event rate, this is very ethical. This is good, because your point estimates are quite likely to be either suggestive of equal efficacy or even better efficacy. Okay? This is a very ethical scenario. And this is an unethical scenario because you have a very lenient threshold. Point estimate suggests harm, but the upper confidence limit doesn't cross that, and everybody's happy because you satisfied the non-inferiority criteria. So once again, the number to look at is, the numbers to look at are the relative risk, which is event rate in the treatment arm, event rate in the control arm, and the number need to harm. So it's essentially estimated by subtracting the event rate in the standard of care in the control arm from the event rate in the new treatment arm. This is the switch you make, because now you're looking at the absolute risk increase, not the absolute risk reduction. Is that clear? You flip them. And then you invert them and you get number needed to harm instead of number need to treat. Is that clear? Okay. So by doing that, you can actually give things clinical meaning. So in our permissive example, a relative risk of 1.33, that threshold for significance actually meant that we're accepting a 33% increase in the risk of the outcome as your worst case scenario. And so let's go into an actual study. The remodel study looked at a then new drug, dabigatran, compared to subcutaneous low molecular weight heparin, enoxaparin, for the prevention of venous thromboembolism after knee replacement. So we usually give people after a total knee replacement, specifically if they're obese and they have decreased ambulation, we give them prophylaxis for a few weeks to prevent the formation of a clot and then a pulmonary embolism. And this was extremely well validated with enoxaparin because you do not need to adjust that by a PTT, and it's a very well validated model with a very low risk of bleeding. So there was this new drug that can be given orally, and that's an advantage. And it's also much more expensive, so that's an advantage to the manufacturer. And they had two different strengths, 150 milligrams and 220, and they wanted to compare them in a non-inferiority design to subcutaneous enoxaparin to prevent venous thromboembolism. So composite outcome of total VTE and mortality, whatever happened first. So how did they estimate the power? How did they come up with the sample size? And what type of increase in the event rate was considered the threshold for non-inferiority. So they said that they wanted to reject the hypothesis that the primary composite outcome with the new drug will be 9.2 percentage points higher than enoxaparin. It's a bit confusing because the way most people write this is the same as percent. But what they actually mean is percentage points, not 9.2%. This is absolute increase, 9.2 percentage points. When the VTE rate of enoxaparin was as high as 48%. So that means they were expecting to have an event rate of 48% in the control arm, people getting the enoxaparin. Okay? So what is the maximal tolerated event rate? What is the threshold for the event rate that they're not willing to tolerate? The event rate that if it's as big as that or higher than that, you're going to say, we are inferior, we cannot switch from enoxaparin. Well, you need to just do the math and add to the baseline of 48%, the 9.2 percentage points they mention as absolute risk increase. And what do you get? You get 57.2%. Then, they don't do this for you, we have to do it. You can transform that into the boundary for relative risk. And if you divide 57.2 over 48%, you get 1.19, which is not bad. To have a threshold for relative risk of 1.2 is actually not that lenient. As a matter of fact, the FDA for the Obama administration said that a threshold for relative risk of 1.20 or 1.22 will be acceptable because in most cases it will mean the point estimate will be on 1 or very close to 1. In the previous administration, they had actually accepted values as great as 2 relative risk units. So this is not that bad. But I'm not going to name the previous one. So what happens, however, when you look at this in terms of absolute risk? Because remember, everything has a relative risk assessment, but it's also, from a societal perspective, you want to know what happens in terms of absolute risk. Because remember, you can change radically the risk of a rare event from taking place, or you can change a little bit the probability of a common event from taking place. So here, you're not accepting a whole lot of harm in terms of relative risk, but when you do the math, just inverting that 9.2% they had, and you transform that into the number needed to harm, that's 11. Now, when we talk efficacy, if you have any treatment that gives you a number needed to treat in the 20s or the 30s, we are extremely excited. That means it's a highly efficacious treatment. So if we apply the same set of values to harm, and if you say my worst case scenario cannot be 12 or greater than 12, your cannot be 10 or less than 10 in terms of number needed to harm, you're actually accepting potentially the possibility of number needed to harm in the 40s or the 50s, which means from a societal perspective, if you switch 50 people, for example, number needed to harm of 50, you switch 50 people from enoxaparin to dabigatran, you get one more VTE episode. How good is that for society? When you move from something that was already working that's actually cheaper and not that hard to implement to something that's going to be more costly and will increase the risk as a societal, at a societal level of having a bad outcome. So what did actually happen? So when they looked at the efficacy outcome, they had 37.7%, about 38% event rate in the enoxaparin. And when you look at dabigatran, if you concentrate on the lower dosage, which is the less efficacious one, you get 40.5%. So in terms of absolute risk increase, how big is that? So the absolute difference is 2.8%, right? And because that upper confidence limit of 8.7 did not cross the 9 they predefined, they concluded both doses were non-inferior to enoxaparin on the basis of pre-specified non-inferiority criteria. So first of all, as I said before, if the event rate in your control arm is lower than expected, that increases the probability of type 1 statistical error, meaning you may say that the new treatment is as efficacious as the old treatment when it's actually not. Yes? Oh, it's a typo. You're right. Yeah, you're right. Yeah, it's probably 1.3. You're absolutely right. I need to look it up. Yeah. Make it up. All right. So, moving on. But this one is correct. It's 8.7, the upper confidence limit. So essentially, this is what they got. They have a situation in which your point estimate is suggesting a almost 3 percentage points increase in the risk of the event. Oh, it's minus. There you go. That's a typo. It's a very wide confidence interval. There you go. So it goes from the possibility that you're actually decreasing the risk of the event to increasing it by 9 percentage points. So from a common sense approach to improving your understanding of this, what's the relative risk? Well, the relative risk is not bad, but look at the confidence interval when you actually plug in the numbers. And then the number needed to harm, the point estimate is 36, which is pretty bad. And it goes from 11 to minus 32. That means this could be number needed to treat. That means that you could actually have benefit. So the point is, you really don't have enough data to say much. This is just a very small study in terms of power, given the lower than expected event rate in the control arm. So you have a situation in which I don't think you can actually make good claims. And if anything, what you can say is, well, I should have conducted a larger study or the same study for a longer period of time. Okay? You see this? So you are actually crossing the relative risk threshold of 1.2. You're going all the way to 1.25. And you're actually, your worst case scenario for number to harm is only 11. So that's really awful. So the pre-combat study was actually also remarkable because it got published in the New England, and they did something really daring. People with left main coronary stenosis, if you occlude that when you're trying to put a stent in, you can actually just kill the patient, okay? And you need to be very close to the operating room so you can crack their sternum open and do a CABG. So essentially, this is not something we do here in the United States. This was a study in South Korea that for some reason got published in the New England. So what they said is, we're going to randomize people to getting a stent or getting CABG, which is the usual approach, for unprotected, meaning there's no collateral circulation protecting the territory of the left main artery. So they said the cumulative incidence of the endpoint in the CABG arm was about 13%, but that included many things, including revascularization within a year. So a whole bunch of really bad things, like death, myocardial infarction, and stroke, and also revascularization. So revascularization, you need to go back to the OR, get another procedure. That's bad, but it's not nearly as bad as dying or having a stroke or a myocardial infarction. So they expected the event rate in the CABG arm, the standard of care, to be 13%. They said non-inferiority margin of 7 percentage points. So now you guys can do the math. It's actually there for you. What's the relative risk? It's 20 over 13, so that's 1.54. That's a very lenient threshold for relative risk. And what they had at the end of the day was 8.7% versus 6.7%. And the absolute risk difference was 2. And the upper confidence limit didn't cross the predefined threshold, and they were able to say not inferior. Reject the null hypothesis. And the number needed to harm, it was said, will be 50. So how good is that? Horrible. They had no actual evidence to really make any claims about non-inferiority. Okay? And it got published in the New England. And nobody wrote a letter saying, this is completely unacceptable. How did the New England ever accept this paper for publication? The editors made them include a little sentence saying that the results were clinically some word, it it was meant to be that it was clinically non-informative or something like that, but they allowed them to publish in the abstract that they achieved non-inferiority. Okay? Doesn't make any sense. So it's just another example of non-inferiority not properly used. So again, going back, this is the checklist you have to go through. This is in your glossary. So what can you do? Well, guys, the reason I keep bringing this up is that it's going to be up to you. Many older doctors have no idea about how non-inferiority is estimated. They have no desire to participate in the conversation. And it's up to you guys to change the tone of the conversation and to put your foot down and say, this is not acceptable. I'm not going to accept this for my patients who may be enrolled in the clinical trial. I'm not accepting this as a doctor for our society. And if the FDA approves a drug or a device because of these findings, I am going to make my case. So it will be up to you to take part in this conversation. Thank you. It's so hard to compete with neuro. Everybody falls asleep. God. I did try to move the course, but it's impossible. I know, it's very rough for you guys. I know. It worked fine.